We have been presenting the results of a trial in adult ALL, particularly in Philadelphia negative patients. And the main points of this trial can be summarized in two different issues. The first one, the trial was based on a pediatric intensification of the treatment protocol to reduce the amount of patients with resistant ALL. And the second point of strength was the molecularly driven evaluation of minimal residual disease that was the guide to allocate patients to a post-consolidation treatment, either with allogeneic stem cell transplantation for those who did not achieve a molecular remission, or to a conventional maintenance chemotherapy program. This latter strategy confirmed, as in the previous study, that this is something very rewarding because we can spare the allogeneic transplant in patients who do not need it. And on the contrary, we allocate to transplant patients who otherwise will eventually relapse. And so the overall outcome has been significant for our experience because the overall survival at 5 years is about 50%, and this is a figure that we have never reached before. Pediatricians have developed very intensive chemotherapy programs that nowadays can cure roughly 90% of children, but this is at the cost of very high-dose chemotherapy. This is something that cannot be easily applied to adult patients because of the comorbidities that adults can develop. And so over the past 10 years, we have been adjusting the schedule of the treatment intensification, finding a balance between effectiveness and tolerability in adults. I mean, in the end, the toxic profile of the study was acceptable. Still, we have a significant proportion of patients who may not achieve the whole chemotherapy program. But again, the early evaluation of minimal residual disease, that represent a way for evaluating the chemosensitivity of the disease. It's very important because we can spare to expose patients to a prolonged treatment intensification, and for those who showed a chemo resistance, they can be allocated earlier to transplantation. And this was a remarkable difference as compared to the previous program, in which the allocation to transplant occurred very late. And this was associated with a cumulative toxicity that proved unacceptable. The improvement of this new strategy has been underlined by the reduction of the transplant-related mortality that in this trial is below 20%. I mean, I think that we are approaching the best that we can get from treatment intensification in adult ALL. But now new molecules are coming on the screen, and they will be very important to reduce the amount of resistance. And this new therapy included particularly the immunotherapy approach with new antibodies, and possibly also with cell therapy approaches that will probably allow us to further improve the outcome in these patients. The importance of adult acute lymphoblastic leukemia is a rare disease, and it's of paramount importance to keep all patients inside clinical trials in order to better understand and to achieve an improvement of the results. If patients are dispersed outside clinical trials, then the information are lacking. And this is something that must be underlined because for many years we had no new molecules. So it's easy to perform randomized clinical trials if you have a new drug to test. But if you don't, then you must continue working on treatment protocols and keeping all patients treated in the same way. And this is the main lessons that we have learned from pediatricians, that despite the lack of new drugs, they have improved the outcome of this disease from 20% early in the 70s up to 90% nowadays, using all drugs.